Hello, my name is Megan Tamarine. I am a BSN RN student at Youngstown State University. I'm doing a narrated PowerPoint presentation on tuberculosis. So, chief complaint. Brian is a 28-year-old Army soldier who returned 2 weeks ago from an 18-month deployment in Afghanistan. He presents to the office with the complaint, I have been coughing for the last month and I'm just not getting any better. He does endorse extreme fatigue that has impacted his exercise routine and unintentional weight loss of 10 pounds. History of present illness. He's a 28-year-old male who presents to the primary care clinic with a persistent cough for 4 weeks. The cough is non-productive, although occasionally he does cough up a scan amount of yellow sputum. Cough is not improved with over-the-counter cough suppressants. He's also reporting fatigue, fevers, night sweats where he wakes up in the middle of the night soaked in sweat, and unintentional weight loss of 10 pounds. He recently returned from an 18-month deployment in Afghanistan and has had no known TB exposure, although several soldiers in his unit were sick with cough as well. Past medical and social history. No history of asthma, smoking, or chronic lung disease. He has seasonal allergies that come and go without treatment. He had 1 to 2 beers a day on the weekends during deployment and denies recreational drug use. Soldier in the Army for the last 10 years. He had 1 18-month deployment in Afghanistan, which he recently returned from. He lived in a communal barracks overseas with over 100 people. Medications, he takes ibuprofen PRN for muscle aches. Doesn't take any other medications. Has tried over-the-counter Robitussin, Dayquil, NyQuil, cough drops with no relief. Allergies, he's just allergic to latex, just causes skin issues, no airway compromise, and no drug allergies. Past medical, social, and family history. Mother's 58 years old. History of heroin abuse, sober times 15 years. History of hypothyroidism. Father is 59 years old, history of hypertension, otherwise healthy. Brian has 2 younger brothers, both healthy. One brother recently enlisted in basic military training, and the other brother is a software engineer. Maternal grandparents still alive, both have a history of diabetes and hypertension, no known family history of chronic lung disease, asthma, or cancer. Review of systems. Constitutional, admits to fatigue, night sweats, low-grade fevers, and unintentional weight loss. ENT, he denies headache, dizziness, visual changes, eye pain, discharge. Denies hearing loss or ear pain, admits to occasional nasal congestion in the early morning. No difficulty swallowing or sore throat. Respiratory, he does endorse persistent dry cough times 4 a week, denies hemoptysis, does report mild shortness of breath during exercise, he denies wheezing or chest tightness. Cardiovascular, he denies palpitations, orthopnea, or syncope, he does admit to mild chest pain when taking a deep breath, denies edema of the lower extremities. GI, he is reporting a decreased appetite, otherwise no nausea, vomiting, change bowel habits, or abdominal pain. GU, he has no complaints related to that. Musculoskeletal, he does report generalized body ache / fatigue, denies joint pain, swelling, stiffness, or weakness. Continuation of review systems. Integumentary, he denies any skin changes. Neurological, he denies any neurological complaints. Psychiatric, he does admit to some anxiety related to returning from deployment, denies depression, insomnia, or suicidal thoughts. Hematological, no issues there. Endocrine, he does endorse an unintentional weight loss, admits to some heat / cold intolerance when he has a fever. Head / lymphatic. He reports feeling a little swollen and tender on the jaw a couple weeks ago. He denies previous history of lymphadenopathy or cancer, denies neck pain or stiffness. Allergic / immunologic. He admits to having some seasonal allergies that come and go without treatment, denies chronic infections or autoimmune disorders. Physical exam. Vital signs are listed on the screen. The only significant finding is temp of 100.3 Fahrenheit. General, he appears mildly ill-appearing. He's cooperative and oriented ×3. Head, ears, eyes, nose, throat. He's normal cephalic, atraumatic, no scalp lesions, conjunctiva and sclera clear and intact, no discharge around the eyes. Pupils +2, bilateral and equally round, reactive to light and accommodation. Tympanic membrane intact bilaterally, no erythema or effusion. He has mild earwax bilaterally. Nasal mucosa pink, non-edematous, no nasal discharge or sinus tenderness. Oropharynx moist and pink, and tonsils are all normal. Respiratory, he has mildly increased work of breathing on exertion. Breath sounds diminish in the right upper lobe with faint crackles, no wheezes or rhonchi, chest expansion symmetrical, trachea midline, no accessory muscle use. Cardiovascular, regular rate and rhythm. He has normal heart sounds, no extra heart sounds, murmur, rubs, or gallops, no jugular vein distension. Peripheral pulses +2 bilaterally, no peripheral edema. GI, abdomen is soft, non-tender, non-distended. He has active bowel sounds in all 4 quadrants, no splenomegaly or hepatomegaly, no rebound tenderness regarding no masses or hernias. GU, there's no complaints that I noticed there. Musculoskeletal. He has normal muscle tone. Strength is 5 out of 5 in all extremities. No joint swelling, erythema, or deformity. No spinal tenderness and gait is normal. Integumentary. Skin is warm, dry, and intact. No rashes, lesions, or nodules. No clubbing or cyanosis of the nail beds. He has mild pallor present. No petechiae or ecchymosis. Neurological, he's alert and orient times 3, cranial nerves intact, sensation intact, DTR is +2 bilaterally, coordination normal, no tremors. Psychiatric, appropriate affect and behavior, he's cooperative and maintains good eye contact, speech is clear and fluent, thought process is logical, no signs of anxiety, psychosis, or depression. Hematological, no unusual bruising, petechiae, or purpura. Endocrine, no thyroid enlargement nodules. Allergic/immunologic, no urticaria or rashes. Mild cervical lymph node swelling and tenderness. No other lymph node enlargement. Diagnostic test and laboratory results. I would do some blood tests, including CBC, BMP, ESR, and quantiferin gold TB test. CBC would show elevated white blood cell at 18,000, anemia, decreased hemoglobin at 9.7. He has increased platelets at 500,000, elevated ESR at 45. All other labs are within normal limits. Quantiferin gold TB test did come back positive. So I would go ahead and do a chest x-ray, which showed right upper lobe infiltration, cavitation, enlargement of hilar and mediastinal lymph nodes consistent with TB. I may proceed to do more detailed imaging tests, as CT scan or MRI, but since he's young and his quantiferin gold TB test came back positive, we can assume it's TB. Sputum culture with AFB smear and drug susceptibility testing. This can detect the acid-fast bacilli that's associated with TB, as well as determine which drugs can be utilized in treatment. HIV testing, just to rule out HIV, which causes immunosuppression, which can cause a patient to be more susceptible to getting TB or other conditions. Differential diagnoses. I would rule out atypical pneumonia since he was around other soldiers that were coughing. It manifests with symptoms similar to an upper respiratory tract infection, but with a non-productive or productive cough. He does have many of the symptoms. It is unlikely that this is the case since he already tested positive for DB, but we can rule that out by getting a mycoplasma pneumonia level in the blood. Pulmonary histoplasmosis, this is a fungal infection often confused with atypical pneumonia. Yet again, it causes the same symptoms, but we can likely rule out given it the positive TB test. Acute HIV infection, yet again, we can rule this out since he had a negative HIV test, but we should rule it out as it can cause issues with infections such as TB and make him more susceptible to getting them. Diagnosis, he has active pulmonary TB. He just returned from Afghanistan, where TB has approximately a 180 out of a 100,000 incidence rate. He had close contact to other soldiers who were sick and traveled frequently to different countries, such as India, Pakistan, who have had high rates of TB. His testing for TB does indicate that he is positive, and chest x-ray shows active disease. Quantiferin gold was also positive given findings in labs and symptoms. This is the primary diagnosis. Treatment recommendations. So I would start him on a traditional regimen for his active pulmonary TB. The intensive phase, which would last for 8 weeks, I'd put him on isoniazid, 300 milligram, rifampin, 600 milligram, pyrazinamide, 2,000 milligrams per kilogram, ethambutol, 1,600 milligram per kilogram, and those would all be taken daily. Those 4 drugs will be taken 7 days, once a day, for 56 doses. The continuation phase, which lasts 18 weeks, he'll just take isoniazid and rifampin at the same dose, and he'll again take those for 7 days a week for 126 doses. Non-pharmacological management, he should avoid alcohol or drugs associated with hepatotoxicity due to drug regimen. Most of these drugs can cause issues with the liver, so we should do baseline ALT and AST just to make sure that he doesn't have any liver dysfunction prior to starting therapy, and then he will have to be monitored monthly while on these drugs. He may experience peripheral neuropathy, which is a commonly reported adverse effect. Rifampin may cause reddish-orange discoloration of bodily fluids, including sweat, urine, saliva, and tears. This is normal, it's harmless. He should isolate himself, remain at home while he has active TB until the doctor says otherwise. He can keep his windows open, use a fan to circulate air, cover mouth when coughing or sneezing. If you do go out, he has to wear a mask and distance himself from others. Follow up. He should follow up monthly to assess for hepatitis and for liver function testing. He should continue to take antibiotics for the entire duration of time, even if you start to feel better. Once he has reached your recommendation for treatment duration, we will obtain a repeat sputum culture and chest x-ray to determine whether TB is cleared or not. Community resources, so I can refer him to the local health department. They can do TB testing, education, referrals for appropriate sources if needed. CDC can also provide educational materials, and TB is also a mandatory reportable disease in the US, so they can offer some treatment recommendations to healthcare personnel who will be caring for Brian. Social media support groups, whether on Facebook, Instagram, TikTok, etc. He can find support groups on social media for other patients who are diagnosed with TB and find some support there. Telemedicine, it may be beneficial to utilize this to limit exposure to healthcare personnel, other patients, etc. Not only can you use telemedicine for keeping up with monthly visits, but it can also utilize it for mental health concerns, considering he did just return from deployment and now he has to isolate himself from others for at least 6 months. All right, here are my references, and I appreciate you listening. Thank you.